All right, good shot, Walt.
4 serving left.
Oh.
Looking like you're a little bit off your game today.
This heat isn't bothering you?
No, not at all. 15 left. You okay?
Yeah.
You want to get a drink of water?
Let's just play.
30 left.
Look, that's it.
You gonna quit in the middle of the game?
No, I don't know. I'm just not. You win, okay? I'm buying lunch.
Middle
you win.
of the game. It's 40 left.
Just give me a minute.
You okay? Hey. Whoa. Okay. Whoa. Hey. Whoa.
We've just seen a cardiac emergency developing, and the patient is going to need expert, timely care when he reaches the hospital. But you're probably saying to yourself, I don't work in the emergency department or CCU. I won't be caring for this patient. That's true. You may not, but that doesn't mean you won't see your share of cardiac emergencies. Common cardiac emergencies, such as acute myocardial infarction or acute pulmonary edema, can occur anywhere and with almost any patient. For example, the patient in for a routine hernia repair, the patient with a hip fracture, the patient with cancer, even the postpartum patient. So whether or not you're prepared for it, you may be confronted with this same type of emergency. Can you recognize the signs and symptoms of a cardiac emergency? Do you know which patients in your care are at risk of developing one? Do you know the techniques and principles used to manage the patient with a cardiac emergency? And do you know how to do the skills you'll be called on to perform? This is the focus of this program. You'll learn skills that will help you recognize a cardiac emergency and anticipate what may happen next, whether or not you intervene or do what's needed to let others intervene. Now let's get back to Brad and see what might happen when he reaches the hospital.
Hello, Mr. Farnsworth. My name is Terry. I'm one of the nurses here. How are you feeling right now?
Fine. You know, I told him there's nothing wrong with me. I don't need to be here.
Well, Mr. Farnsworth, since you are here, why don't you try to relax and let us determine if everything's okay? Then we'll both know whether or not you need to be here. Are you having any discomfort right now?
Yeah, a lot.
Can you describe it?
Yeah, it's a heavy feeling, a dull pain. You know, like there's a huge weight right here in my chest.
On a rating scale of 1 to 10, with 10 being the worst, how would you rate your discomfort?
It's about an 11.
Are you feeling discomfort anywhere else?
Yeah, my left arm is numb. I mean, it tingles.
When did your chest discomfort begin?
I guess I really had it on and off all morning. And I may even have awakened with it. I just thought I overdid it at a party, but when I started playing tennis, you know, it really hasn't stopped. It really ruined my tennis game.
Mr. Farnsworth, this is Dr. Pfeiffer. He'll be caring for you here in the emergency department. Has your discomfort improved at all since you stopped playing tennis?
No, not at all.
Are you having any difficulty breathing?
I was at first, but that's better.
Has this ever happened to you before?
No, never.
Are you allergic to any medications that you know of, Brad?
No.
Then let's give him some morphine. Start on 2 milligrams IV push and titrate it. Better start some lidocaine too. 75 milligrams bolus ought to do it. And a 2 milligram per minute IV drip. Brad, we need to run an ECG to know for sure what's happening, but it won't take long. I suspect, however, you're having a heart attack.
Oh, come on. I'm not having a heart attack. I'm in good shape. I don't even need to be here.
As you know, an acute MI is a serious cardiac emergency. It's life-threatening because of the damage to the myocardial tissue, which may cause pump or heart failure. Ventricular irritability may also develop, which may lead to sudden death from serious cardiac dysrhythmias, such as ventricular fibrillation. Recognizing the emergency is the key to prompt intervention. Diagnosing it is also critical and is based on 3 important findings. As you'll discover in depth later in this video, the first is a history of chest discomfort or pain and other symptoms consistent with myocardial infarction. The second finding is a group of changes consistent with myocardial infarction in the 12-lead ECG. And the third finding is an elevation of the CPK isoenzyme MB. A positive history and ST segment and Q wave changes by themselves are not conclusive evidence of acute MI, but they strongly suggest acute myocardial damage and tissue necrosis. An elevated MB is conclusive evidence, since it specifically indicates cardiac cell damage. Now let's talk with Terry, the nurse we just saw in the emergency department, about the signs and symptoms she looks for in the patient. Terry, when you see a patient you suspect might be having an acute MI, what information do you want to obtain?
Well, one of the most important aspects of the assessment is to get past the denial that is often present in such a patient.
As in Mr. Farnsworth's case?
Exactly.
What made you suspect an acute MI?
Well, when a normally healthy person, even a hospitalized, stable patient, is pale, diaphoretic, having chest discomfort as he described it, and has a blood pressure of 150/98, you must consider an MI. Although he didn't report any nausea or vomiting, he had many of the other classic symptoms of acute MI, such as shortness of breath and left arm discomfort.
Tell us more about the chest pain commonly associated with acute MI.
Interestingly, many patients do not report pain, but rather discomfort. Mr. Farnsworth described his discomfort as being a heavy, dull feeling. Some patients describe it as a gripping, pressing, or squeezing. Mr. Farnsworth went on to locate his discomfort as being substernal and radiating to the left arm. Other patients describe the discomfort radiating to both arms, the neck, jaw, back, epigastric area. It's also important to learn how long the patient has had the discomfort. Mr. Farnsworth had experienced these feelings on and off for a couple of hours when they became unrelenting on the tennis court. They were unrelieved by rest, changing position, or deep breathing.
So what happened next?
We ran a stat 12-lead ECG and drew blood for total CPK and the MB isoenzyme. We also did other blood tests in preparation for treatment.
Any results yet?
Yes. Here's a copy of his 12-lead ECG. It shows typical changes of an anteral septal MI. The ST segment is elevated at least 2 millimeters in leads V2 through V4. ST segment depression is seen in leads 2, 3, and AVF. Q wave changes are also apparent.
What about the enzymes?
We won't get them back until tomorrow morning, but I suspect the CPK will be over 100 and the MB isoenzyme will be greater than 4%.
So what's happening with Mr. Farnsworth now?
Right now, we're starting a second peripheral IV line for the administration of thrombolytic drugs. Remember, we already have one peripheral line for the lidocaine drip.
Why thrombolytics?
Thrombolytic drugs, such as streptokinase, help to dissolve the clot that is formed and block the artery. Dissolving the clot quickly results in the least amount of heart muscle damage, leaving left ventricular function preserved. If the pain has been present for less than 6 hours, thrombolytic therapy is the treatment of choice.
Let's go back to the emergency department and learn more about thrombolytic drug therapy. Thrombolytic drugs are usually started in the emergency department before the patient is transferred to the CCU. The patient must receive a lidocaine drip along with the thrombolytic drug because of the risk of certain dysrhythmias. In Mr. Farnsworth's case, the doctor ordered 1.5 million units of streptokinase to be infused over 60 minutes. Most patients also receive heparin and aspirin along with the thrombolytic drug. As you might suspect, you must also closely monitor the patient for any signs of bleeding. For this reason, not all patients should receive thrombolytic drug therapy. For example,
anyone who is over age 75, has had recent surgery or trauma injury, has a history of stroke or recent active peptic ulcer disease, is not a candidate for thrombolytic drug therapy. In addition, anyone who recently had CPR, is pregnant, has blood dyscrasias, or uncontrolled hypertension should not receive this treatment.
Since the clot often occurs in a coronary artery already narrowed by atherosclerotic plaque, coronary angiography is performed to determine the extent of the atherosclerosis. If a tight coronary lesion is found, angioplasty may be performed within 48 to 72 hours after admission. During percutaneous transluminal angioplasty, the doctor inserts the dilating catheter into the stenotic area. After advancing the catheter to the desired location, multiple balloon inflations, each generally taking from 3 to 60 seconds, achieve dilation of the artery lumen. In addition to thrombolysis and angioplasty, other key interventions include rest, analgesia, mild sedation, a quiet environment, oxygen, and blood pressure control. Maintaining a positive balance between the myocardial oxygen supply and demand is the goal of treatment.
Although the heart's function is to pump oxygenated blood to all body tissues, including the myocardium, it may not perform well enough to provide optimum cardiac output. Optimum cardiac output depends on several things. An adequate amount of venous blood returning to the heart. This is sometimes called venous return or preload. Myocardial tissue that contracts properly during systole and that relaxes properly during diastole. This is referred to as contractility. Unobstructed and unidirectional flow of blood through the heart's chambers, valves, pulmonary circulation, and aorta, resulting in an adequate afterload. A normal heart rate of between 60 to 100 beats per minute. And an adequate systemic vascular resistance reflected by diastolic blood pressure. A cardiac emergency exists when one or more of these factors change because of cardiac disease, infection, or trauma, or disease affecting another organ system, such as kidney disease. Left untreated, a cardiac emergency could result in cardiogenic shock, cardiopulmonary collapse, or death. Let's look at some potential cardiac emergencies, beginning with myocardial infarction. Myocardial infarction is caused by a clot forming at the site of an atherosclerotic plaque that has developed in the lumen of a coronary artery. It may also be caused by an intense spasm of a coronary artery. If blood flow to the myocardium is totally obstructed beyond the clot or spasm, compromised myocardial function occurs almost immediately, and cellular death or tissue necrosis may result. The size of the affected area determines the amount of cardiac muscle loss, and consequently how much cardiac output will be reduced. Acute left-sided ventricular failure results in pulmonary edema or cardiogenic shock and is another cardiac emergency. The most common cause of left-sided ventricular failure is hypertension, but more than half of all patients who have a myocardial infarction will also develop left-sided ventricular failure. Because the left ventricle can't pump blood effectively, cardiac output decreases, leading to shock, and blood backs up in the pulmonary system, leading to acute pulmonary edema. Acute pulmonary edema occurs as pressure increases in the pulmonary vasculature. When the pressure exceeds the pulmonary capillary oncotic pressure, fluid leaks into the interstitial space surrounding the alveoli. Eventually, the alveoli become fluid-filled as well. The engorged tissues are stiff, and oxygen-carbon dioxide exchange is impaired. The pericardium is the protective sac surrounding the heart. Cardiac tamponade, which is another cardiac emergency, occurs when fluid accumulates in the pericardial space. If the accumulation is rapid, such as occurs in chest trauma, as little as 250 milliliters of fluid will cause tamponade. Cardiac output is significantly reduced because the heart's chambers are compressed, which impairs filling during diastole. If the accumulation of fluid is slow and gradual, such as occurs in pericarditis or cancer, the pericardium can stretch to accommodate 1,000 milliliters or more of fluid before cardiac output is affected significantly.
What's wrong, Mr. Davidson?
Short of breath. I can't get my breath.
Well, tell me more about how you feel.
Feel full in the chest. Hurts a little.
Mr. Davidson has cardiac tamponade caused by post-radiation pericarditis. But the most common cause of tamponade is bleeding into the pericardial space after cardiac surgery. Other causes include trauma, tumor, tuberculosis, acute viral or idiopathic pericarditis, renal failure during dialysis, or cardiac perforation by arterial catheters, for example. The recognizable clinical signs and symptoms of cardiac tamponade are related to decreased cardiac output and systemic venous congestion. Let's go back and watch as Teresa assesses Mr. Davidson. During your assessment, you'll probably note dyspnea and orthopnea, as well as cool, clammy skin, anxiety, restlessness, or confusion. Your patient may also complain of fullness in his chest. Chest pain related to pericardial inflammation may or may not be present when the fluid accumulation develops slowly, but sharp stabbing pain is often present when the tamponade develops rapidly. This pain is aggravated by breathing and coughing and becomes worse when the patient is lying flat in bed. Despite the dyspnea, the lung fields sound clear during auscultation of breath sounds. But during auscultation of heart sounds, you'll note several changes. Tachycardia is present, and the heart sounds may be diminished, faint, or muffled. You may also hear a pericardial friction rub. Hypotension is usually present when the fluid accumulation is large or when the problem has occurred rapidly. Another significant finding is pulsus paradoxus, or paradoxical pulse. To check for this, first ask the patient to breathe normally, then palpate his radial pulse. When cardiac tamponade is present, the pulse volume, measured by amplitude, decreases during inspiration. This happens because during inspiration, right ventricular volume is increased, which causes the ventricular septum to shift to the left. Because left ventricular filling is restricted, cardiac output decreases and the pulse volume is decreased. You can also estimate the degree of pulsus paradoxus. To do this, inflate the blood pressure cuff in the usual manner as the patient breathes normally. Then begin to deflate the cuff slowly and evenly. You'll first hear the carrot cough sounds during expiration only. Record this reading. As the cuff continues to deflate, you'll reach a point when the sounds are audible throughout the respiratory cycle. Record this reading. The difference in these two readings is the estimated degree of pulsus paradoxus. When cardiac tamponade is present, you'll note a difference of 10 millimeters mercury or more. Another finding associated with cardiac tamponade is increased venous pressure. To evaluate it quickly, assess the patient's jugular venous pressure, or JVP, as follows. Make sure the patient's upper body is elevated at a 30 to 45 degree angle. Now locate the internal jugular vein, which is located under the sternocleidomastoid muscle and is parallel to the carotid artery. It may be easier for you to find the external jugular vein first, and then look for the pulsations of the internal jugular vein.
Internal jugular pulsations are seldom palpable, and they have a soft, undulating quality when noted. You can eliminate them by applying light pressure. The pulsations descend during inspiration, and they also vary when the patient changes position.
When you locate the internal jugular pulsations, find the highest point of pulsation and place a square-cornered rectangle of paper horizontally at this point. Next, locate the sternal angle where the patient's manubrium and sternum connect at the second intercostal space. Place a centimeter ruler vertically over the sternal angle. The level of the sternal angle is the 0 point. The point where the paper intersects the ruler is the JVP reading. Normally, this vertical distance is less than 3 centimeters. If you want to estimate right atrial pressure, a reflection of central venous pressure, add 5 centimeters to your measurement. If this total measurement exceeds 10 centimeters, then consider the patient's central venous pressure elevated. You may also note a positive Kussmaul sign as you measure JVP. This sign is present when the jugular veins fill during inspiration. The patient's liver may also be enlarged, and a decrease in urine output may also be present. A chest X-ray may reveal an enlarged globular heart, and an echocardiogram may show the fluid accumulation as well as pendular heart motion. A 12-lead ECG will reveal other changes consistent with cardiac tamponade. Typical findings include low-voltage QRS complexes and electrical alternans, seen in some leads. Electrical alternans is present when the amplitude of the QRS complexes varies in an alternating pattern. During cardiac catheterization, the patient's right atrial pressure is elevated, which reflects an elevated pericardial pressure. Diastolic pressures are the same in each of the heart's chambers. Although detecting cardiac tamponade is seldom easy, rapid recognition and intervention are essential. Always suspect tamponade in patients who develop the telltale signs and symptoms of tamponade and who have predisposing conditions. Once a diagnosis of cardiac tamponade is made, you can anticipate that several things will happen, depending on how acute the cardiac emergency is. Mr. Davidson has been taken to the cardiac cath lab for pericardiocentesis. Other treatment options include open chest drainage, pericardiectomy, or a pleuropericardial window. Plans will be made to send him to the intensive care unit after the procedure. No matter how the doctor plans to treat the patient, your role is to plan and prepare the patient. Explain, as needed, the procedures and equipment to the patient and his family, and continue monitoring him. Some interventions you can start immediately. These include administering oxygen to maximize oxygen saturation, establishing a large bore intravenous access for administering parenteral fluids to increase cardiac filling and improve cardiac output, and for administering emergency drugs. In this case, Mr. Davidson is receiving vasopressors. Let's take a look at another clinical problem that involves reduced cardiac output as well as altered pulmonary gas exchange.
Mrs. Hagen was admitted about 9 last night. She had been experiencing shortness of breath, which had worsened during the day. On admission, her ECG showed normal sinus rhythm. Several years earlier, she had been diagnosed as having mitral stenosis. At present, she's stable and has been since admission. Her BP 140/90, heart rate 92, respiratory rate 22.
Mrs. Hagen, what's wrong?
Can't get my breath. This is what happened last night. It's worse now.
Her respiratory rate is really increased, 36 breaths per minute, and her blood pressure has dropped too, 100/76. Are you coughing up anything?
Yes.
Is it pink and frothy?
Frothy. Lots of bubbles.
Inspiratory bibasilar crackles, some wheezes. Her heartbeat is irregular, at a rate of about 160. Diminished pulse pressure and a pulse deficit. Can you tell me anything else about how you're feeling?
My heart, it's flip-flopping.
Diaphoretic, pale, cool skin. Capillary refill slow. Jugular vein distension. No pretibular ankle edema. Mrs. Hagen, I'm going to call your doctor, but first let me put this oxygen mask on you.
What signs and symptoms of low cardiac output did you notice? What do you think is wrong with Mrs. Hagen? Before we go back to her, let's talk a little about acute pulmonary edema and heart failure, both related events. If the underlying problem develops slowly, as in Mrs. Hagen's mitral stenosis, compensatory mechanisms that tend to increase cardiac output are usually effective. But as end diastolic pressures continue to increase over time, or if another problem develops that by itself would affect cardiac output, acute pulmonary edema occurs. In Mrs. Hagen's case, the development of atrial fibrillation with a rapid ventricular response was the precipitating cause. The management objectives for Mrs. Hagen are to decrease cardiac workload, enhance myocardial contractility, and control excessive sodium and water retention. Let's see what interventions were ordered by Mrs. Hagen's doctor.
Yes, Dr. Granford. The blood gas measurements just came back. pH 7.29, PaO2 is 68, PaCO2 is 46, HCO3 is 24. The stat chest x-ray shows enlarged pulmonary veins in the upper lobes, a hazy confluent pattern throughout the hilar region. Oh, and the potassium level is 4.0.
Lasix 40 milligrams IV push for diuresis and digoxin 0.25 milligrams PO to convert the atrial fibrillation are ordered by the doctor. He also ordered morphine sulfate to reduce preload and for sedation, which will help to decrease oxygen consumption. Mrs. Hagen's nurse should also anticipate the need for intubation and possible mechanical ventilation if her condition worsens. Whenever the heart's ability to pump an adequate cardiac output is compromised, a cardiac emergency can occur. These situations don't happen just in the emergency department or the intensive care unit. You must be alert for a cardiac emergency wherever you work. Let's review some of the important points discussed in this program. First, you must be able to recognize the signs and symptoms of reduced cardiac output. Even subtle changes in the patient's clinical status may be important clues in detecting a cardiac emergency. Be ready to administer oxygen. Providing oxygen therapy is an essential intervention to prevent hypoxemia, hypercarbia, and acidosis. Anticipate the need for IV administration of emergency drugs by providing an IV access route. Take steps to reduce cardiac workload. Since the heart's ability to function effectively is already compromised, these interventions are essential to the patient's ability to survive and recover. Monitor the patient carefully and accurately. Doing so helps you determine the effectiveness of the interventions and helps you detect any developing complications. As a nurse, you're frequently in a position to recognize a cardiac emergency as it is developing, and by doing so, prevent cardiogenic shock, cardiovascular collapse, and death. Although in many situations, you may not actually perform the interventions, the time you've gained for others by anticipating the patient's needs can be those precious moments required to save his life.